What's Up, Doc Mike? Public Health on Call, by Johns Hopkins Bloomberg School of Public Health. Today's topic for January 18, 2021, State Health Departments and Vaccine Distribution Challenges. Thank you, Johns Hopkins Bloomberg School of Public Health.
Welcome to Season 3 of Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Josh Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former Secretary of Maryland's Health Department. Our goal is to bring scientific evidence and experience to the public health news of the day through informative interviews with scientists, community leaders, policy experts, public health officials, clinicians, and more. If you have ideas or questions for us to cover, please email us at publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Today, our topic is vaccine distribution. I'm speaking with Michael Frazier, the Executive Director of the Association of State and Territorial Health Officials. We talk about the challenges states are facing in setting up massive vaccine distribution programs and what it will take to get more life-saving vaccine to the people who really need it. Let's listen. Mike, thanks so much for joining me on the podcast to talk about vaccine distribution. When did you and your colleagues at this state health departments realize the kind of challenge that vaccine distribution would be?
Well, thanks for having me, Josh. Vaccine distribution has always been on our minds. I think it was mid-summer when we first, started thinking about what it was going to take to roll out this monumental activity. And that's when we started really thinking about what resources states and territories would need to effectively do community vaccination. And our advocacy agenda started pretty much in the summer, early fall to push for those resources for states.
So what were you asking for? What did you imagine states needed?
Well, there's so many unknowns when it comes to this vaccine. There still are, even though we've got two products. And early on, we asked for resources to support the data systems so we could track where vaccine was going and who was getting it, communications campaigns to help address hesitancy issues and some of the concerns. If you remember back to some of the concerns about speed, we were really concerned that folks would be wary of taking the vaccine. So communications resources and, of course, workforce, people to actually do the vaccinations themselves. If we're going to get this done quickly, public health departments need a lot more human resources to make it happen. So those are the three big buckets.
And you were asking for that funding in the fall, the summer heading into the fall. When did you get more resources?
We got more resources appropriated from Congress the last week in December of last year. So it was a long haul down. It was a nail biter.
So that was basically a month after the vaccine had been authorized.
Correct. So early on, there was $200 million and then another $140 million that were distributed to states from CDC for vaccine planning. And the assumption that the administration had was that there wasn't any new money needed. And we were actually told that by several HHS officials, that states had what they need and the vaccine was covered, insurance could be billed, and all the supplies, ancillary supplies needed would be provided by HHS directly to the states. And we disagreed with that. And fortunately, Congress appropriated new resources. It was pretty late, though.
Yeah, and I want to get to that point because when the vaccine launched, those resources hadn't even been passed by Congress. And even now, those resources haven't really reached states. So what were the consequences? What are you seeing out there right now from your vantage point?
Well, right now, first, I just want to say everybody's working as hard as they possibly can. And honestly, not to be on the defensive, but I think some of the critique of the rollout is just not justified when you think about the scale and scope of this activity. And the fact that the real issue for a lot of this is being able to anticipate the supply, not the actual work at the state level. So, just to get that out there. But honestly, I think things in states right now are going pretty well, considering the initial rollout here was really focused on long-term care facilities, and the plan there for most states was to turn on what's called the pharmacy program, where the federal government is working directly with CVS, Walgreens, and another group of independent pharmacies to get them to do the clinics in long-term care facilities. So they're responsible for that, where the pharmacy program is turned on, and that's a fair number of states. And then the other piece of this was to deliver vaccine to hospitals and health systems that are pretty fluent in vaccine delivery and get the healthcare workers vaccinated. So that was always the plan, and that's what we're doing now. There are some states that have changed their approach to vaccinate individuals who are not necessarily in the ACIP priority groups, those CDC guideline recommendations to vaccinate 75-year or older Americans first. But we're going to see that. We're going to see those state variations based on how much vaccine they have, what the demand is, and everybody calls that chaos and lack of consistency. But you know what it is? It's states meeting the needs of their states, and we see that with lots of places.
So let's go to the first group, healthcare systems and nursing homes. As you pointed out, those really don't require a huge amount of state work. It's really just shipping the vaccine to the hospitals, and the hospitals go from there. And it's having this pharmacy program that the federal government set up. Get out there and try to vaccinate the staff and the residents of nursing homes. But that has not gone as swiftly as people had hoped, and there are a lot of unused doses. What do you think the reason for that is?
Well, there's a couple. So, first of all, these vaccines are delivered in very fixed quantities. Those allocations come, the state requests an allocation, but the final allocation comes from Operation Warp Speed. So Operation Warp Speed is the spigot here to turn on vaccine distribution. And they do ship directly to facilities based on what the state allocation is. The issue is the delivery of these vaccines, the ultra cold storage requirements, the refrigeration requirements. One of these products is packaged in doses of 975. One of these products is packaged in doses of 100. They aren't split, so you're not going to send 975 doses of vaccine to a small clinical provider. They're all going to go to a hospital and health system that can manage that, and it's got to be a facility that has the demand and the ability to use up all of that vaccine. And that's where we see a little bit of surplus in some of these facilities where the demand doesn't necessarily meet the supply that they have. And then you hear these anecdotal stories about, people walking down the street and someone pulling them into the hospital to get vaccinated. I don't think that's the exception, not the rule, but there is the maldistribution in some places because the demand wasn't necessarily what folks thought it would be in some places.
And now we move from that more controlled distribution that was supposed to be the easier part to the more complicated distribution, where states have different priority groups and different approaches, and really where you were asking for a lot more money to be able to be prepared.
Yeah, a community vaccination program of this size and scope is not. It has never been done before, but it's the bread and butter of public health. When you think about what we do every year when it comes to seasonal influenza or back to school. It's just a lot of vaccine. So, I think the point there is the rollout to facilities and the work with the pharmacies was very instructive. I think public health in many ways was planning on community-based vaccination clinics, or what is also called mass vaccination clinics, to always be part of this plan, just to do it later in the spring. Everybody wants to know why that's not happening now. It's not happening now because there's not enough vaccine. Nobody knows what the supply is going to be, in a month out. And until we get some more transparency around the supply issue, I think folks are going to be putting plans together, but they're not going to be holding clinic when there's no vaccine to deliver.
Why is it so hard to know about the supply if it's being manufactured on a schedule, do you think?
Well, I'm not sure, honestly. The process that Operation Warp Speed uses is pretty opaque to me. I think what we've heard from states is similar in that the allocations promised are less than what they were expecting, and they do change, so it's not predictable. And I think a lot of that has to do with just early production and kind of the ramp up of the two different products. But it's our hope, and we have some confidence from the federal agencies that will become more predictable. It will become more clear. But right now, it's not very clear.
So to a certain extent, the states have been in a bit of a holding pattern, you're saying, as a result of not really knowing how much vaccine is coming.
There was a holding pattern when it comes to vaccine supply. There's a little bit of a holding pattern, or there's a major holding pattern when it comes to resources to actually get this thing to work. And by the way, I mean, those dollars still need to come from the federal agencies to the states and then be obligated. So that's going to take a little while. So that's a holding pattern.
And how much was in that appropriation?
So total, about $8 billion, a little more than $8 billion. I can't believe I'm being so cavalier with the number that big for public health. What we know of is that the first piece of that coming from the federal government, CDC, straight to states through the Vaccine for Children program will be about a $3 billion initial investment. In addition to that, there's another $19 billion coming to states for other aspects of COVID, which include surveillance and some of the data issues, as well as testing, contact tracing, and case investigation. So we're looking at huge new investments in public health for COVID in every state and territory.
So focusing in on the vaccines, from a state perspective, as this money comes in, what does this allow the state to do? What will we start to see states doing when this money becomes available?
I think the three biggest areas where we'll see states ramp up is acquiring the workforce. So really contracting probably with a lot of groups that can quickly stand up vaccine clinics without having to hire full-time equivalents in the health department, when on this very time-limited resource. So we'll see procurement specifically to vaccine providers. We're all getting ready for that, looking at what that will look like, as well as passing that through to local health departments as a provider to do vaccine clinic at the local level. We're going to see some of the technology improvements. We've heard about the scheduling issues and people waiting in line overnight for vaccine and websites crashing. Well, that's because everybody's doing this on a shoestring, and this will allow for, I think, some really scaling of those IT solutions and building the IT systems that states have. And finally, I think we'll see a lot more communication, public information campaigns, really micro-focused messaging on communities about the vaccine, where to get vaccine, and addressing hesitancy and concerns about the vaccine. That states will be able to do a lot with these resources.
That's great to hear. What do you think about the idea of health departments taking vaccine to specific groups that might not sign up or wander in on their own? Going to high-risk workplaces, high-risk senior housing. Do you see like a outreach vaccination effort happening in different states?
I think we're going to see a lot of different innovation that's actually going to be really exciting to watch, which is probably mobile vaccine clinics. This notion of everybody's got to come to the health department and wait in line. It's a bad idea for COVID. It's a highly communicable disease. You don't want to have big groups of people standing around waiting to get vaccinated. So I think we're going to see folks going to places, smaller settings where the vaccine can be delivered safely without large crowds. We're going to see kind of micro clinics, as well as there are some new models of kind of mega vaccine kind of drive-through facilities. I know they're standing up some of those in New Jersey today. So we're going to see a lot of different innovation in vaccine delivery.
So maybe just to wrap up here, this is one of the biggest challenges that public health departments have ever faced, to deliver successfully a vaccine to so many people so quickly against a new disease in the middle of a pandemic. I get the sense that, everybody is working flat out, that finally resources you've been asking for, $8 billion, is going to start coming available. All this should add up to a lot more people vaccinated. What do you think the critical elements for success will be if we look ahead 6 months, having a lot of people vaccinated, high levels of confidence? What are the critical things that state health departments are going to have to be successful in doing?
I think the two places that I'm most I'm watching the closest are the velocity of this, so how quickly folks can be vaccinated, as well as the equity issues. Are people who need the vaccine first getting it? And to me, those are the two factors we spend a lot of time thinking about.
Great. Well, thanks so much for joining me.
Absolutely. Pleasure.
Public Health on Call is produced by Josh Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by Spencer Greer, Niall Owen McCusker, C.N. Oates, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo and Neiman Outland. Social media support from Brenda Haggader, Grace Holes Fernandez, and Caroline Wong. Thank you for listening.